Okay, well, hello everyone, and welcome to another session of the Virtual Global Spine Conference. My name is Ali Baaj. It's a pleasure to be here with everyone. I thought this today would be a nice topic to review, which is in some ways a little bit different to many folks, especially perhaps in the neurosurgery world. But I really like this topic. It's one, as I put online, it's really the intersection of pediatrics, traditional orthopedic spine, neurosurgery, and it's a really nice review of both pathology, physiology, as well as really nice spinal surgical techniques. So we're going to talk about syndromic scoliosis today and how it often is different or similar to other types of scoliosis like adolescent idiopathic scoliosis as well as congenital scoliosis. So it's a pleasure to be here. This is March 2024. Again, this is a really special month for us, to me and a lot of my colleagues at Virtual Spine who put this program together now 4 years ago. This month is the 4-year anniversary of Virtual Spine. Took a lot of effort early on around the pandemic to get this going. Really delighted to work with a great group of hosts and panelists, and of course a special thanks to a lot of our our loyal audience and participants, many of whom have been with us from day one. So it's an honor to keep this program going on a weekly basis for everyone. So let's go ahead and get started with the talk today. First, I want to acknowledge a couple of folks here. Dr. Esteban Caseño, who's a past research fellow with us. He's now a research fellow at the University of Buffalo. He helped me put together some of these slides for a previous presentation. And of course, another acknowledgement to Dr. Ryan Miller, who is one of the pediatric orthopedic surgeons here with us. I consider him my partner when it comes to pediatric scoliosis. He's really good in that, and we try to collaborate on some of these cases. So a little bit of self-promotion here, so I apologize, but I really think this is a nice review for a lot of folks, especially in the neurosurgery side, who want to obtain a good overview of pediatric spinal deformity. I had the honor of working with a few neurosurgeons here who are really all experts in pediatric spine. And this is a neurosurgical focus, so it's open access, it's free to anyone. And it's a compilation of maybe about 12 or 14 articles on pediatric spinal deformity. And again, it's a little bit dated here, 6 or 7 years ago, but I actually still look at it and review some of those papers frequently to just remind myself of some of these rarer pathologies, if you will. So again, you know, I have a special interest in this topic because, as many of you know who train outside of the US, but especially in the US, we in neurosurgery, classic neurosurgical training, have only recently really adopted more of pediatric spine training in our training programs and of course in fellowships. We're very good in training as far as pediatric brain tumors, tethered cord, Chiaris, etc. But I think for a long time we were a little bit deficient in actual spinal deformity correction, and I think we're slowly integrating that into our into our training programs. You know, we have on an organized neurosurgery or on a national level. This is an interesting topic because even in orthopedics, sometimes that could be a conundrum, right, or an issue between pediatric trained orthopedic surgeons or adult trained spine orthopedic surgeons. So pediatric deformities in kind of, it's like a Venn diagram. It overlaps with so many different specialties. And I think in neurosurgery, I've been advocating for this for a long time. We need really more structured training in pediatric deformity in conjunction and collaboration with our orthopedic colleagues, but it's something that we have not done very well in, and many of us, like myself, needed to go and do some specialized pediatric spine training. But getting back to the topic today, so the topic is syndromic scoliosis. And the reason I became interested in this is, you know, quite frankly, because a lot of these syndromes, if you will, were neurosurgically or neurologically related, right? Like Kiari, tethered cord, split cord malformation, things that as neurosurgeons we have to know about, we get consulted on, we need to know how to manage. And then, of course, as a spine trained neurosurgeon, that's where I put, okay, my spinal column hat on, and how do we not only take care of the spinal anomaly, but how do we evaluate and how do we treat the associated spinal deformity? And this is what we're talking about today. Many folks are familiar with the most common type of scoliosis, for example, in teenagers, which is called idiopathic scoliosis, right? AIS, or adolescent idiopathic scoliosis, is the most common form. And there's some key differences between syndromic scoliosis or syndrome-related scoliosis and AIS. Number one, the rates of, and this is really the most important slide, so I'm going to spend a couple of minutes on this. The rates of curve progression tend to be a bit more unpredictable in syndromic scoliosis. So in AIS, you have these charts, let's say it's a half degree to a degree, every year or so. You get a film maybe every 6 months to every year. Syndromic scoliosis do not follow those same patterns. They don't play within the same rules as the traditional AIS do. So surveillance is more critical. Surveillance is more important and critical. Perhaps the timing of intervention is a little bit more critical as well. So people have to understand that it's not like, okay, let's get an X-ray every year and see what happens. At some point, there may need to be imaging at a sooner time period for patients with syndromic scoliosis. A lot of people ask, and parents ask, about bracing. We know that bracing has a very important role in adolescent idiopathic scoliosis, especially for curvatures, say between 25 and 45 degrees in the growing spine. Syndromic scoliosis, a little bit different. Although bracing may still be prescribed, we don't really know that the curves and the magnitude of the curve will listen to, if you will, or will respond to bracing the same way that AIS does. So you can't really 100% or significantly rely on bracing in syndromic scoliosis like you otherwise would in AIS. There's some talk about the type of correction and the degree of correction with syndromic scoliosis. In AIS, you see a lot of the folks here that put stuff online and in papers, and you get like a 70, 80 degree AIS curve, and after surgery, it's a perfect straight spinal column. And that may be possible in AIS. In syndromic scoliosis, there are other factors, and sometimes that is not possible or even safe, like neurofibromatosis, syrinx-related, Kiari-related scoliosis, as I'll show in a few cases later. So the surgeon has to be a little bit cognizant of the degree of correction and the extent of correction due to potential neurological injury. One thing that, and then the fourth item here that I think is important for everyone to understand is, although there may be exceptions, depending on several factors, the textbook answer or the standard is, if let's say a child, teenager or a young child has advanced scoliosis, but they have an obvious symptomatic Kiari or a symptomatic tethered cord, or for that matter, any spinal anomaly, the classic teaching is we want the spinal issue to be treated first, whether it's the Kiari, whether it's the tethered cord. And that's to diminish the risk of neurological injury with scoliosis correction. And some folks, let's say if it's a very mild Kiari or a mild tethered cord, some advocate for treating both at the same time. But when in doubt, if there is a symptomatic spinal, neurosurgical or neurological issue, you want to treat that first, and then the deformity. And we'll talk about some research on why that's important. So I really think this is an important take home slide for everybody to keep an eye on. Now, some of these slides, some folks here have seen these before, so I apologize. But for those who haven't, just kind of, play along. And I'm going to ask some 3 or 4 questions, write down the answer, or you can put them in the chat box, and we'll see how you did. Because I'm going to ask these same questions at the end of this 25, 30-minute presentation. So here's the first question, and really, I think these 4 or 5 questions highlight the essence of this talk, and that's why I want to emphasize them. Here's the first question. An 18-year-old female presents with back pain, no symptoms, no radicular symptoms, no myelopathy, no evidence of neurological compromise, and she has a 25-degree main thoracic curve, 25-degree main thoracic curve. She's 18 years old. What's the best treatment? Is it surgery? Is it bracing, MRI, or close observation and maybe follow-up? So if you're comfortable with putting your answer on the chat box, go ahead and do that. If you want to hold off until later, that's fine too. Somebody put yoga. I think yoga and physical therapy are phenomenal treatment. They're an important part of the treatment modality of any patient with scoliosis, by the way. But from the options here, I have a lot of D's, close observation. So we'll see if you're right or wrong at the end of this session. Here's question number 2. A 12-year-old premenarchal girl presents, let me move my slide here a little bit because I can't see it. Presents with uneven shoulders. She's neurologically intact. There's no lower extremity deformity. Scoliosis X-ray shows 45 degrees. So now you have a 12-year-old girl, premenarchal with a 45-degree, let's say, main thoracic scoliosis. So 45 degrees, 12 years old. Now what do we do? Are we doing surgery because the patient has a larger curve? Does it matter that she's 12 and the other patient was 18? We're going to talk about that a little bit. But what does everybody think here? Surgery? Do we brace and re-image? Do we get an MRI, right? When is an MRI indicated? When do we get MRI in scoliosis? I think that's a question that's important to address. Here's question number 3. 6-year-old boy has symptomatic tethered cord, primary tethered cord. He also has a 25-degree thoracolumbar scoliosis. So tethered cord, scoliosis. What is the next best thing to do here? Do we operate on the tethered cord? Do we do surgery for both tethered cord and the scoliosis correction, or do we just do the scoliosis correction and see what happens? Again, this is making assumptions, but from these 3 options, which one is the best way to go? So we have a lot of A's here for this one. We'll keep an eye on this and come back to it later. This may be the final question, or there may be one more. Again, we kind of talked about this a minute ago, but if you want to aim for a perfect scoliosis correction, or really perfectly aligned in the sagittal plane and the coronal plane scoliosis correction, where is that mostly achieved? Is it in AIS, or is it in neuromuscular or syndromic scoliosis? We're gonna also address that. All right. So those were just 4 or 5 questions just to set the stage for what we're going to be talking about. And some things to consider. A brief overview of the types of pediatric scoliosis, if you will, or the things the types of scoliosis that any surgeon would see in a pediatric population, adolescent population. Certainly, you have the congenital, which is obviously very rare. That's when you see a hemi-vertebrae, either one or single level or multiple hemi-vertebrae. Neuromuscular scoliosis is a common one for folks who see a lot of patients with say cerebral palsy, paralytic, scoliosis, spina bifida. Those tend to be neuromuscular, and they're driven. The scoliosis is driven by really a dysfunctional neurological system, central neurological system that has driven this scoliosis. We're going to spend a little bit more time on the topic of this talk, which is a lot of us neurosurgeons see these patients, which are patients with syndromic scoliosis, Klippel-Feil, Marfan's, OI, achondroplasia, Kiari, tethered cord, right? Those are all scoliosis that are related to specific syndromes. And again, the reason we see them a lot as neurosurgeons is because they tend to have neurological dysfunction. They tend to have myelopathy, spinal cord lesions, et cetera. And that's why we get involved. And then I'll just spend, I'll just probably spend a slide or two on AIS because it's so common. And I think it's important for everybody to review AIS in the bigger context. But this is what we're going to be addressing today. As far as how do you assess this, how do you assess somebody with scoliosis, with syndromic scoliosis? It's not really very different than adult scoliosis, right? You want to see standing films if possible, bending films to assess for flexibility, supine films, again, to assess for sagittal flexibility. A big question comes with when do you need an MRI? Okay, you see somebody says, hey, my family friend's cousin or my neighbor's son or daughter has scoliosis. They said they have 25 degrees. What do you think? And a big question is, do they need an MRI or not? And I answer that in usually two ways. Number one, and we'll, if you have our co-hosts on the line today, they can correct me. But number one, we're getting MRIs more and more. MRIs are in most areas are becoming a little bit more affordable, less expensive, easier access to MRI, and surgeons don't want to miss, quote unquote, miss a finding. And I think more and more patients are getting MRIs. That's probably a fact, certainly in a lot of our regions here in the United States. The real answer, or the academic answer, the textbook answer is, if somebody has a neurological dysfunction or has a rapidly growing curve, an unusual scoliotic curve, yes, an MRI is indicated to see what is going on, what is driving that unusual curve pattern or that unusual rate of progression. So if you have a very large curve, young patient, or rapid progression, an MRI is indicated. Similarly, if a patient is presenting with myelopathy, radiculopathy, you also need an MRI. And the one case that I show a lot online, and I know others other adult surgeons can relate to this, is sometimes you have these patients come in, young adult patients with scoliosis that are curved like that, and everybody thinks they need scoliosis surgery. But when you actually do your history and exam, it turns out that, oh, this has been going on for 2 weeks and they have a lot of leg pain. Well, that's a sciatic scoliosis, or that's a, reactive scoliosis. But their main problem is a large disc herniation, right? So a history and exam are very important. And anytime there's neurological issues, bowel issues, bladder dysfunction, numbness in the lower extremities, we're really pulling the trigger on the MRI quickly to make sure they don't have an underlying spinal anomaly. So I hope that answers that. A quick word or two about congenital scoliosis. And one thing I'll say about that is they're not a lot of these patients that require surgery, in the sense that sometimes you actually have hemi-vertebrae that are stable and don't cause progression. What is important, and this is something that I tell my team, is the most important thing is not to miss other syndromes, or not to miss other abnormalities. So these patients need renal, cardiac abnormalities, because if they have cardiac and renal issues, especially cardiac issues, they have a higher rate of progression. So it is important to identify which types of patients you need to keep a much closer eye on or not, and counsel the patients whether they're going to have rapid progression or not. I put this case online. This was a 17-year-old who came to me with an untreated hemi-vertebra. And now, over the years, he had back pain, and now he has both a coronal plane and a sagittal plane deformity. And this was a hard case, right? I mean, he's already rigid. He's 17 years old. I told him, I said, I wish this were treated before, but that's the case in all spinal deformity. We wish they were treated when the patients are younger because they have more flexible spine. So we chose to limit the extent of instrumentation to allow more mobility at the cost of some residual coronal and sagittal plane malalignment. But he ended up doing very well. He's 3 years out now, this particular patient. And that's an example of a hemi-vertebrae. We definitely like surgical correction sooner than later. AIS, again, the most important thing about idiopathic scoliosis, especially for the neurosurgeons who may see these in their clinic, or they may get consulted on, is they shouldn't have neurological issues. They shouldn't have leg pain. They shouldn't have numbness or tingling, bowel and bladder dysfunction. Otherwise, it's not AIS. It's not idiopathic. There must be another reason. Now, a lot of these patients come with back pain, right? So is back pain a red flag? Is back pain an indication to do surgery? You've got to take that into consideration, but you have to think that a very active, say 16 or 17-year-old male or female who's playing sports, gym, carrying a big bag, they're going to have back pain, right? If they're very active. And so you have to differentiate that from true neurological dysfunction. There are several ways to look at skeletal maturity. Obviously, one traditional way is this Risser grading score. We're looking at the ossification of the in the pelvis or in the ilium. I can look at the X-ray of the palm of the hand. And actually, there are some folks now that are looking at biomarkers, a lab assay to look at to determine the skeletal maturity. So whichever method you choose, it is important to know what the skeletal maturity of this patient is, right? Because and this is one of the most important slides. Again, a little bit dated, but it still is very important, which is the peak growth velocity for males and for females. Because remember, a 12-year-old who's premenarchal is going to grow a lot differently than an 18-year-old who's postmenarchal, right? Who's already skeletally mature. And that has an impact on how you counsel them as far as their scoliosis is concerned. So younger patient, more likely for the curve to progress. Older patient, less likely for the curve to progress. And, there are a lot of charts out there as far as, what's the cutoff. For most people, 25 to 50 is probably bracing. You may be a little bit more aggressive if you see a rapid rise in or a rapid growth progression. But for most folks, 25 to 50, you're probably either watching or you're putting in a brace. Over 50, if they're skeletally immature, or if even they are skeletally mature, you really want to start considering surgical intervention. But, I tell patients, or I tell colleagues, the most important thing is surveillance, observation, getting to know your patient. Don't make a surgical decision based on scoliosis after one visit. You've got to have a few data points to make that decision and find out what is their trajectory, what is their progression. It's different from patient to patient. But the bottom statement here really summarizes it very nicely, which is, at the end of the day, the larger the curve and the more skeletally immature the patient is, the higher the likelihood they're going to need surgery. Young patient with a big curve is going to need surgery. Older patient with a smaller curve, unlikely to need an operation. These are, again, they're different. I don't know, let's see if this video will play, but there are different techniques to correct scoliosis. AIS, a little bit different than the neuromuscular or syndromic. You can do the rod derotation. You can do segmental en bloc derotation. There are a lot of really nice videos out there and styles. These are a couple of AIS cases from my personal case log. The one on the right, which we actually achieved an excellent correction, is one of my first cases, long time ago. And you can see that because the implant density is very low. I didn't use a lot of pedicle screws, but she was very, very mobile, and we were able to get a good correction. The one on the left was a standard main thoracic that was causing a lot of back pain. So there are different strategies, and we're not going to talk about implant density and how many screws you need to put or not. But in general, the less the lower number of levels you need to fuse, the better. The goal is to either correct or maintain the curve, preferably correct the curve with minimum number of motion segments that you need to take, because you really want to spare motion segments for patients. This is a patient, interestingly, that came to me who previously had AIS surgery outside of the country. I'll show you her x-rays. She was very imbalanced and had some broken screws at the bottom. There's a lot of ways to handle this. By the time she saw me, she was in her early 20s. She had fractured screws below, as you can see here on the right. So we decided to extend up and down. do some Pontes, and you know, a lot of these are PCOs. These are posterior column osteotomies. You don't need to do a PSO or a VCR on these idiopathic, especially at the adjacent segment. So you know, she ended up doing quite well. So I guess the reason I show this case is because it's not just about screws or rods. Scoliosis surgery is not about instrumentation. A lot of us would agree, especially with navigation and robotics now. Instrumentation is probably the easiest part of the case, right? It's the decision making as far as where you start, where you stop. So what's the UIV, what's the LIV, the degree of correction, and to make sure you're not getting an adding on phenomenon or adjacent segment, you know, proximal or distal junctional failure. It's not about the screws or rods. It's really about technique and the planning. Everybody would agree with that in scoliosis, adolescent scoliosis surgery. Back a little bit, and I like Dr. Selby saying, you know, 100% go shorter in my line now. I agree with him. You know, right now we really want to do, you want to spare as many motions as possible, and he's one of the experts in both fusion and VBT, vertebral body tethering, which I don't do, but there's also non-fusion and motion sparing technology now that is very promising, and maybe we're due for a virtual spine session on non-fusion strategies in adolescents. Of course, this is a talk about fusion surgery, but there are a lot of other innovative techniques. But yes, we do want to go shorter to maintain motion for patients nowadays. Now, getting back real quick to Chiari's, tethered cords, things that as neurosurgeons we're going to see a lot of, or a lot more commonly. We know that scoliosis can be associated with Chiari's 1 and up to 20%. And we also know that once patients have, you know, large syrinx or syringomyelia, they can have neurological deficits. So the question is always, what do you do first? Do you do the Chiari or do you do the scoliosis correction? I like this slide a lot. You know, this is based on existing data. In younger patients with small coronal with smaller Cobb angles, the posterior fossa decompression, let's say in this case Chiari decompression, decompression could actually, you know, potentially lead to resolution or improvement in the spinal deformity. So a lot of people say, oh, well, fix the Chiari, the scoliosis will get better. True and not true. If it's a large deformity, if it's 40, 45, 55 degree, it's not going to get better. A 55-degree curve is not all of a sudden going to improve with a Chiari decompression. But if you've got a 20-degree curve, 15-degree curve in a growing patient, in a growing spine, yeah, there is a good chance that there may be either arrest of that scoliosis, or even better yet, a correction, auto correction, if you will. So that alone is a reason to not do a Chiari decompression as well as scoliosis correction surgery at the same time, especially for a mild curve. Now, you know, some folks are challenging this long-held hypothesis that, you know, Chiari should always be done first. You know, there are some surgeons, and there is some thought that if you have, let's say, a Chiari or a mild or a small syrinx that's asymptomatic, it was found incidentally. Somebody got an MRI, the small syrinx or the small Chiari, you know, which one, you know, what do you do? I think there's enough evidence to suggest that if somebody needs a scoliosis correction surgery and they have a mild, asymptomatic, incidental Chiari, you probably can get away with the scoliosis correction surgery, with the deformity correction. But this is why multidisciplinary discussions are important here. It's important to talk with neurosurgeons, neurologists, et cetera, to determine what's the best course of action. Again, I gave you the textbook answer. The textbook answer is do the Chiari first, but there are exceptions, and it's important to know that there are exceptions. So this is actually this is a case that I did with one of our pediatric neurosurgeons. This is from a few years back. A patient who had a Chiari, I think multiple Chiaris, really needed OC fusion for a different reason, and we're not going to talk about that today. But preoperatively, after the, you know, before the Chiari, he had a large 60 or even 70-degree curve. Never got better. Okay, that obviously did not get better. It was 70 or 80-degree curve. And then we waited about 3 months and then went back to do to fix or to at least stabilize the thoracic scoliosis with some improvement in the Cobb angle, and really more importantly, in my opinion, improvement in the sagittal plane. And again, how long do you wait between surgeries? I think 6 to 12 months is probably, 6 to 12 weeks is the right answer. If somebody has a small curve and you want to see if they'll autocorrect, 6 weeks may not be enough. You may want to wait 3, even 6 months, or even a year to see whether they actually would autocorrect their deformity. But we knew this patient was certainly not going to have any substantial improvement in the thoracic curve. He was 14, and this was a large, stiff curve. It wasn't really a significantly flexible curve. This is a more recent case, actually. This is a 20-year-old female who came to me with progressive scoliosis, but she also had bladder dysfunction. And it's interesting because she was referred to me for the scoliosis. And again, we do a proper history, proper exam. And to be honest with you, that caught my attention a little bit. And so we did the MRI, and lo and behold, it did demonstrate a tethered cord or a low down below. So she actually had cord detethering first, and about 6 or maybe about 8 weeks later, we did the this thoracolumbar scoliosis correction. She did really well. I just saw her recently at the 1-year anniversary, not too long ago. X-rays looked good. She was happy, and her bladder function improved. She actually had some numbness and tingling after the cord detethering, but now it almost completely resolved. But it took her a full year to resolve the neurological symptoms. But again, history and physical exam are really important. This was a mild, let's say mild to moderate curve. The right answer is to do the cord detethering first. All right, moving along here. This, everybody knows what this is. These are 2 syndromes that we see a lot. Especially if you deal with syndromes. Does anyone have put in the chat box what they think this is? There are 2 separate diagnoses, one on the left, one on the right. Somebody said winged scapula. That's correct. What do we see winged scapula with? So NF1, correct. NF1 is on the left. Those are cafe au lait spots. And on the right is winged scapula associated with what? It's a different diagnosis. Very good. KFS, Klippel-Feil syndrome. So Klippel-Feil syndrome, we see a lot as neurosurgeons because a lot of those patients come in with autofusion in the cervical spine, stenosis, and cord compression. And Dr. Kumar here correctly pointed out that, I apologize, we call it winged scapula, but it's really a Sprengler's deformity. Sprengler's deformity in which the scapula is autofused to the cervical thoracic junction. And I'll show you what that looks like. NF1, very common, one of the most common autosomal dominant conditions we see. Certainly has a lot of neurosurgical implications in terms of tumors, neurofibromas, ependymomas, and certainly a notoriously challenging condition when it involves scoliosis. And that's because scoliosis can be either dystrophic or non-dystrophic, and the dystrophic ones are really hard. Skeletal dysplasia, small pedicles, poor, large dural ectasias. Those are some of poor bone quality. Those are some of the hardest ones to treat. And the problem is the more severe the dystrophic changes, the more severe the scoliosis is associated with NF1, the higher the rate of progression. So it's a vicious cycle. The more challenging ones are the ones that actually are going to progress and cause issues. And that's why NF1 is one of the most challenging conditions to treat when it comes to scoliosis. Again, dural ectasias, right? I mean, nobody wants to deal with CSF leaks and dural issues, but unfortunately they're common. Small pedicles and just really, really challenging conditions, especially when there are large neurofibromas that are driving that scoliosis. Resection of these large, sometimes plexiform neurofibromas are not possible. So a lot of this is, just damage control, if you will. This is like, heroic efforts, damage control surgery. But these are very, very challenging conditions. High complication rates, perioperative complication rate, 14%. Revision surgery is very high. I'll show you one of my own cases that had complications. Actually, it was this patient right here. This young boy, he was 13 years old. He was referred to me, was treated with growing rods, the traditional growing rods, not the magic rods, for a long time. And then he, maybe a little bit older, maybe 14 or 15, developed cervical thoracic kyphosis, lots of neck pain, and they had moved, and they couldn't see the other center, and so he was fused below, but it wasn't fused on top. No, we used navigation, we used it all. Down here he was fused, so I wasn't worried about the bottom, but I was really worried about the top because we just didn't have good lateral masses or bony anatomy to put screws in. So we really took a chance with him. Clinically, he did really well. Radiographically, he did very well. You can see, even the coronal deformity below was better. The sagittal plane was better. This construct, he held it for 2 years, about maybe more, maybe 2.5 years. And then unfortunately, he had fractured rods right here that needed revision back in another center. So, this is not easy stuff. This is very hard for these patients to fuse, even if you use BMP and everything else. So NF1 is hard. KFS, Klippel-Feil, is not as challenging per se as NF1, but anatomically it's a little bit different because sometimes patients are short stature, there's autofusions, so it's a little bit more challenging. This is one of my cases, again, from a few years back, a young girl who had a stiff 73-degree curve, had almost like a bar, almost like a congenital bar fusion in the thoracic spine. Again, very low implant density because she was flexible above and below. So we didn't need a ton of implants there, and we got a very acceptable correction. Clinically, she was happy, but those are hard. And if they're hard to make, you can make them look straight if you do a VCR and everything else, but we were not going to put that 11-year-old into, we're not going to put her through that risk. So, and this is another patient, again, Klippel-Feil, large lumbar curve, very happy with this mild to moderate, I would say acceptable correction. So KPS we see quite a bit, again, because of the cervical autofusions, but we've got to be able to manage the deformity as well. So getting back to those questions, let's see how everybody did. I think everybody got this one right. 18-year-old female presents with back pain. So she's 18, 25-degree curve, and no myelopathy, no radiculopathy. So technically, there's no indication for an MRI. And certainly, the best thing to do is maybe close observation and follow-up, right? I tell patients, just as a good measure, just as good patient care for them or for their family, I may have them get maybe one more X-ray in 6 months or even a year, just to make sure I have 2 data points, especially if it's the first time I meet them. But in essence, a curvature that's less than, say, 30 or 40 degree in a skeletally mature patients, unlikely to be problematic for many years to come. So everybody got that one right. I think everyone got this one right too. 12-year-old premenarchal girl presents with uneven shoulders, no limb deformities. What's the next best step for this one? This one is tough, right? It's 45 degrees. So it's like, okay, it's in the middle, right? It's in the middle because this is the first time you're seeing this patient. Now, if you saw this patient 6 months ago and it was 10 degrees and now it's 45 degrees, you may have a different thought. But if you're seeing this patient for the first time, 45 degrees, premenarchal. So we know she has not reached, she's right there at her peak height velocity. Bad things can happen pretty quickly here. And so you really want to re-image in 6 months. I think bracing is indicated for these cases in which it's 25 to 45 degrees. Patients are still growing. This is somebody you don't want to rush into surgery. You want one more data point, and you want to see what happens to her curvature and to her scoliosis. I've talked about this enough now, especially for the neurosurgeons. If you have a symptomatic spinal anomaly, symptomatic either from a large syrinx, from a Kiari tethered cord, you really want to take care of the spinal anomaly first and watch the scoliosis for a little bit. You don't have to watch it forever. If it's 60 degrees, you got to do it. But if it's, let's say, 25, 30 degrees or less in a growing patient, in a growing spine, probably a good idea to take care of the spinal anomaly and keep an eye on that. And again, this is just to highlight the fact, this question is to highlight the fact that perfect scoliosis, you want to be careful in syndromic scoliosis and neuromuscular scoliosis. The risk of neurologic injury is higher than AIS, because AIS, the spinal cord is fine. They have a lot of functional reserve. They have a lot of neurological reserve. So you want to be careful that you're not trying to kind of be a hero in surgery, getting that perfect correction, but then ending up with a neurological injury. So closing up here with this first slide that I put in the beginning, syndromic scoliosis is different than AIS. The rates of curve progression are unpredictable. Bracing is not typically helpful. I'm not saying we're not going to use it or don't prescribe it, but you have to counsel the patients and their families so there's no false sense of treatment. And you got to tell them bracing is probably not going to work here, but certainly it's unlikely to hurt unless there are pressure points and wounds and stuff like that. You got to keep an eye on that. Partial correction due to the risk of neurological injury, and treat the Kiari tethered cord first. Those are general principles of syndromic scoliosis. Dr. Baisa is saying for question number 3. Let me go back to question number 3 here. Let's see. When would you recommend VBT or magnetic rods with 45 degrees curve in a premature spine? Very, very good. And I'm glad Dr. Selby answered it. So Dr. Selby, by the way, you can unmute yourself, Mike, if you want to speak. But that I was going to say that, I don't think it's a bad idea for, let's say, growing rods or non-fusion in that age group. I probably would still watch it. But Mike, what do you think? Welcome.
Thank you, Ali. Thank you.
What do you think about this specific question?
This specific question's a tough one. I mean, the Sanders is going to be, nothing basically. So, 6-year-old, 25 degree. I think, you're definitely going to do tethered cord surgery and then bracing. I found that bracing can definitely work in these younger kids with, say, Kiaris or syringomyelia or tethered cords, but it's not as reliable. Let's say, if I had a kid with early onset scoliosis and a 25 degree curve and I braced them, I can get complete reversal of that because you get high compliance at this age, right? If it's an idiopathic and normal child, often you get great results. Now, not always, but I find that the ones with concurrent neural axis issues, it's 50-50 is what I tell the parents. And, I think there's some literature behind that, but I think you definitely give that a go. And I think if you did have progression within the brace, then magnetic rods, I still think they're great. I mean, I know there's issues out there and they now recommend changing every 2 years and removal, but magnetic rods are great. VBT has pretty tight parameters to be effective. And I think you can certainly go too early with VBT. And in boys, often too early for VBT is even 10 years old, right? They get overcorrections. So I think if you've got, that just closing triradiate, Sanders 2 to 4, perfect for VBT. But a smaller kid like this, if you failed bracing and as Dr. Baessa said, let's say that curve had gone to 45, 50 degrees despite bracing, I reckon magnetic rods are still a good option in my hands for this. I don't know what you think, Ali, if you're still using magic down in
No, not really. I mean, even the orthopedic colleagues I work with aren't really doing them, to be honest with you. I think they're, maybe that's a US thing, but we definitely fuse earlier. I would say, severe curves, 10, 11, 12 years old patients, we're probably a little bit more aggressive on fusion versus non-fusion. But VBTs, not for the syndrome, but for the AIS, I mean, a lot of folks are pushing that.
Yeah, I think if someone is a normally mature 10-year-old, and I think judging bony maturity is always really hard, right? But if someone is a normally mature 10-year-old, then a definitive fusion is not bad. Absolutely. I think below 10, I have some concerns. But, I think there's some good papers out of the US on fusion for neuromuscular scoliosis can be definitive, 10 and above. Absolutely. In that they don't seem to lose much respiratory capacity or anything really from the age of 10 onwards. And so it's only those much younger kids you're looking at all these growing options, which I think I'm just battling at the moment with the thought process on a kid of mine that's got magic rods in from when she was 6 and she had a neuromuscular curve and she's done great with it. It's held her, she's got balanced 50-50 curves. And I've still got these magic rods in that aren't causing a problem. Now, what do I do? Because the company says we should be taking them out,
That's right.
So I don't want to put a kid with neuromuscular scoliosis, all sorts of orthopedic issues after her last hip and knee surgeries through an unnecessary operation, right? The rods haven't broken, they've probably auto-fused. So
Exactly.
magic does lead to some tough decisions that aren't always straightforward.
Yep. Yeah, no, great insight. Thank you. Thanks so much, Dr. Selby. We're going to have to get you to do a session on VBT. I think there's a lot of interest in that, and I think that will complement these talks very nicely.
Absolutely.
Wonderful. All right. Well, thank you, everybody. Let me go back. I think that's it. I want to thank everybody for joining us today. Again, a little bit of a different topic here. Appreciate Dr. Selby's insight. And what we'll do is we will defer until next week, and we will advertise who is what the session will be like next week. So thanks to everyone for joining us on behalf of the Virtual Spine team, and have a great afternoon or evening. Or for Dr. Selby and our friends in Australia, have a good morning. Take care now.
Thanks, Sally.